All right. Well, good afternoon, everyone, and thanks for joining us. My name is Lisa Vertinsky, and I'm a professor of law here at the University of Maryland, Francis King Carey School of Law. And on behalf of the Law and Healthcare Program and its director, Diane Hoffman, I want to welcome you to this final finale event of the 2025-2026 Rothenberg Healthcare Law and Policy Speaker Series, where we focused on the future of food, drug, and medical device regulation. We've had an amazing lineup over the course of this year, including Professor Patty Zettler, who spoke on why FDA's crisis is everyone's crisis, the past, present, and future of FDA reform. Professor Rachel Sachs, who talked about the challenges of regulating health technologies in a post-FDA world, and Peter Lurie, President and Executive Director of the Center for Science and the Public Interest, who shared his perspectives on the future of food and nutrition regulation. And today's speaker, Dr. Reshma Ramachandran, is the perfect speaker to conclude our series. Before we hear from her, I want to share just a tiny bit of background about the Rothenberg Speaker Series. It was started 6 years ago as we were finding ways to connect virtually, and we continued the virtual format, and we found it to be a wonderful way to bring health law scholars and practitioners into our health law community to share their insights in the most cutting-edge issues facing the field. We're grateful for the generous funding from the Karen Rothenberg and Jeffrey Setzler Law and Healthcare Program Endowment. And indeed, Professor Rothenberg has been a powerhouse and continues to be a powerhouse. She was the former dean of the law school and founder and director for many years and continues to contribute in ways like this. Today, we're thrilled to close out this year's virtual series by welcoming Dr. Reshma Ramachandran. She's an assistant professor, board certified family physician, and health services researcher at the Yale School of Medicine. And I've been a fan of her work. Her research focuses on the realignment of incentives for healthcare stakeholders, including pharmaceutical companies, hospitals, and universities, looking at this realignment towards prioritizing equitable patient access to safe, effective health technologies, something that's really increasingly critical in today's world. She co-directs the Yale Collaboration for Regulatory Rigor, Integrity, and Transparency, an interdisciplinary initiative aligning research on medical product evaluation, approval, and coverage to advance policies that improve patient health and healthcare. And prior to this, she worked as research faculty as part of the Innovation and Design Enabling Access Initiative at the Johns Hopkins Bloomberg School of Public Health, where she focused on policies to address the global challenge of antimicrobial resistance and unaffordable access to prescription drugs, challenges that still continue to persist. She was trained in both medicine at the Alpert Medical School at Brown and then public policy at the Harvard Kennedy School of Government, completing her family medicine residency at Kaiser Permanente, Los Angeles Medical Center, and the Health Services Research and Policy Fellowship at the National Clinician Scholars Program at Yale. She's also on the board of directors for the nonprofit organization Doctors for America. And she does a bunch of other things, but I want to leave the rest of the time to turn it over to her. So without further ado, I'll turn it over to Reshma.
Thank you so much, and thank you so much for having me. I'll go ahead and share my slides so you can see them. There you go. Okay. All right, so today I'll be talking about FDA's curtailed authority to regulate lab-developed tests, something that I'm increasingly seeing in my own clinical practice and also seeing in various advertisements and websites that are being directed to my patients, and talk about what this means with FDA not being able to take its usual role as a regulator in ensuring that these tests are truly effective and also relay results that are accurate for patients. Here are my disclosures. I don't take any funding from any commercial entities that produce any healthcare related products. And also some of the nonprofit organizations that I work with are listed here as well. All right, so kind of first question, what are lab developed tests? It's actually a very unique type of diagnostic tests. They're actually designed, manufactured, and used within a single laboratory. Initially, when they were introduced in the mid-1950s and earlier than that, they were intended to be in-house tools that were tailored to specific needs of a community or a hospital or a particular area. Now, how do these tests differ from other in vitro diagnostic tests, and what are some examples? So just thinking about some broad categories, we have commercial in vitro diagnostic tests. These are made usually by kind of a large medical device company, mass-produced, and then evidence around its clinical validity, so whether or not it actually provides results that are meaningful for patients, and also its analytical validity, whether or not between one device manufactured and another, there's consistency in results. That is actually reviewed by the FDA before it comes onto market, and there are some caveats I'll put with that. These are meant to be sold and distributed widely, so there'd be multiple labs that get access to these tests and also run these tests and provide interpretation of these tests. Then you have lab-developed tests, which are a small subcategory in the larger area of in vitro diagnostics, which are meant, again, to be designed and used in one laboratory. And initially, these were in academic medical centers where you had pathology departments of folks who were looking at a particular patient population and trying to be able to find ways to diagnose various issues, or to be able to look at blood samples to identify markers of disease. So all this are designed, manufactured, and used in-house, and the interpretation also happens in-house. And these are not intended to be sold or distributed to other labs. But overall, all these tests are meant to provide us as clinicians and also patients guidance in terms of how to proceed with their medical care. So there's a long regulatory history for lab-developed tests, and I put this here just to be illustrative. That is, this has been kind of a multi-decade sort of issue that FDA, but also other health agencies have dealt with. And you can see, starting back in the 1970s, but even today, we're seeing a lot of changes happening in this space. And just for the reference for one of the pieces that we had written last year in JAMA Health Forum about the public health implications about some of the recent changes related to this test. So happy to send that over along with copies of the slides. So let's kind of take a step back to 1976, when FDA's kind of regulatory authority around lab-developed tests really emerged. So this was the medical device amendments that were actually added to the Food, Drug, and Cosmetic Act, which actually gave authority to the FDA around regulating medical devices just generally, using what we call a risk-based approach. It introduced this idea of having classes of different medical devices, class 1 devices being low-risk devices in which FDA could not require information or data being provided to the agency around its effectiveness ahead of approval, and then class 3 devices, which we call high-risk devices. Within that, LDTs or lab-developed tests were considered to be low risk at the time. This explicitly included just in vitro diagnostics altogether, and again, adopted this risk-based approach. And I'm going to kind of repeat that over and over again, because with medical devices, there is this sort of enforcement discretion that FDA has used based on how they view the risk of a particular product to a particular patient population that it's indicated for. So in 1976, when the medical device amendments was actually passed and included as a part of the Food, Drug, and Cosmetic Act, the LDT industry was really in its infancy. We had technologies like PCR testing that had yet to be commercialized, so this is pre all of that, and companies that might be familiar to you, like Quest Diagnostics or LabCorp, they would be publicly traded companies for decades. So this is really early on, where there's very few tests, usually in academic medical centers, being used for a particular location. At that time, the diagnostics kind of fell into two categories. One where you had standardized products that were sold to facilities. So an example of this would be automated differential cell counter devices that are used to look at complete blood counts. So if you got in test results from your physician around white blood cells or red blood cells or platelets, this is a part of that. Or you had bespoke tests that were developed by individual laboratories for in-house use. Again, this idea of LDTs. And these were customized tests that were sometimes used to look at enzymatic metabolic disorders, and also looking at staining protocols for different bacteria to be able to identify an infection that might be endemic to a particular area. And you can see, illustrative here, kind of mass use commercialization versus kind of in-house use to be able to guide clinical care. So what does it mean for FDA to apply a risk-based approach to diagnostics? And this is how FDA has talked about this in guidance documents that clarify how the statute around the medical device amendments were being implemented. So we have diagnostics for broad distribution, where generally FDA needs, generally you need FDA approval before marketing authorization. So before patients can actually access these tests, before they can be ordered by a clinician, there had to be some sort of FDA approval process. Manufacturers generally had to provide clinical or non-clinical evidence of safety and effectiveness to the FDA. And this included both information related to whether or not the diagnostic test accurately identified a disease or condition or a marker of that, but also performance standards for that particular test as well. Most of these were considered to be moderate risk. So FDA has some enforcement discretion, and generally, especially right now, a lot of these moderate risk devices go through a process called the 510(k) process, in which only a few of them undergo pre-market clinical testing. However, all of these are still subject to this idea of providing performance standard information, so non-clinical information, to the agency so they can make sure that the test is going to be safe for patients to be able to use. FDA, as I mentioned before, exempted lab-developed tests because they consider them low risk. And what that allowed was that laboratories could market LDTs without any sort of FDA oversight. You did not have to file an application with the agency. You could actually kind of directly sell to consumers or to patients once you've developed a test. This was exempted again from pre-market review, so no performance standards in terms of how the tests operate, and also no post-market surveillance. So the idea that even after the product comes to market, there will be a way to be able to track whether or not there's variation in different populations or issues with the tests, if there's changes in the disease. All of that was not required for these tests as well. And again, these are considered to be low risk due to the very infrequent use for these. Quickly, though, we saw that there was gaps in the regulatory paradigm for LDTs, and this is from 1988, about 12 years after the medical device amendments was passed, and some news investigations, including from the Washington Post, and then congressional hearings that led to this. So the news investigations actually exposed substantial performance variation for lab-developed tests that were performed in physician office laboratories, in particular for cervical cancer testing and cholesterol blood tests. So you have some patients who might get a positive for a cervical cancer test that was developed from these LDTs, and then others who would not, and there would be high rates of false positives or false negatives, both which can be very detrimental and delay care for patients as well. And then on top of that, the development of these molecular testing technologies like PCR testing, like I mentioned before, that were integral to the public health response for the HIV/AIDS epidemic, illustrated the consequences of allowing diagnostics to enter clinical practice without undergoing FDA review. So there was an investigation as well looking into LDTs for HIV that found false positive rates up to 90%. So for a patient, what does that mean? There's a possibility, a very high possibility, they would take a test and it would show that they were positive for HIV despite the test being wrong. And this spurred a broader congressional inquiry, and this is from the Committee of Small Business in the House of Representatives, where they put out a report as well as had a hearing called Deadly Mistakes, Are Laboratory Tests Reliable? From this, Congress decided to take action, but interestingly, they decided to actually look towards CMS. And the reason they did so was that they thought this reflected an extension of CMS's existing authorities to ensure that healthcare facilities, so laboratories, met minimum standards for quality rather than abrogating FDA's role in ensuring the safety and effectiveness of diagnostic tests. So CMS got new regulations, primarily around laboratory standards, making sure you had enough people in the facility, that the labs had the correct equipment, that certain quality metrics related to the lab were being met. These were all under CMS's sort of CLIA requirements, or the Clinical Laboratory Improvement Amendments that were passed in 1988. The final regulations were passed in the early 90s, and interestingly, there was actually a citizen petition from the LDT industry that went to FDA that made this case that actually CLIA made FDA's oversight of lab-developed tests under the medical device amendments actually moot. This was actually rejected by the FDA in 1998, And FDA actually reasserted and clarified its authority to regulate lab-developed tests and medical devices, but that they had taken this position of enforcement discretion, given that these tests are low risk. But if there was a chance that these tests moved out of the low-risk category, then FDA could use its discretion to be able to provide enforcement based on the test risks to patients. So it's kind of interesting to kind of see this sort of split between agencies in terms of regulatory oversight and then the subsequent consequences of this as well. So just kind of to clarify this for everyone, further, CLIA under CMS, or the Centers for Medicare and Medicaid Services, really assesses the idea of analytical validity. Really, can the test actually accurately measure whatever you're supposed to be measuring? The biomarker, the marker that you're hoping for that might be a proxy for the disease, etc. The idea is that it's supposed to be able to look at quality metrics that are measuring the technical performance of the tests, and also in-lab metrics as well, including the human sort of interoperability of these tests, and also validating the method around the tests as well. So really looking at kind of the laboratory standards that are around these tests. FDA's purview in relation to these tests is really around this idea of clinical validity, and this is just general across diagnostics overall. Do the results from these tests actually relate to a disease or condition that is meaningful for patients? And what it measures is patient-level performance, clinical outcome metrics, so really directly trying to measure how patients feel, function, survive, or some sort of marker that's indicative and associated with this, and also validating clinical use for this. Are these tests actually useful in clinical practice in terms of guiding care? So this is really how the split came in terms of the regulatory oversight here. But because, again, LDTs were considered to be low risk, FDA used its enforcement discretion to not require any sort of evidence around clinical validity before these tests reached patients. I'll just say, this created a lot of confusion and really created a paradoxical regulatory regime for LDTs because of the split and also FDA's use of enforcement discretion. In the midst of all this, what it led to is a rapid growth in domestic commercialization. By 2015, about 2 decades later, we saw that there was over 2,000 labs that were offering LDTs and over 11,000 LDTs that were being made available directly to patients. There was also a massive change in the laboratory business model for LDTs. It was no longer individual laboratories that were in academic medical centers or in single health systems. Now it was actually large corporations that were increasingly marketing high-risk, complex diagnostics for broader use. So more similar to kind of a traditional medical device company rather than these smaller kind of mom and pop shops or kind of smaller labs within an individual office or clinic or within a hospital. And just to kind of stress again, in that citizen petition around enforcement discretion, FDA also provided this sort of key justification for this, saying that these diagnostics were being developed and used in limited capacity by individual laboratories, typically operated in academic hospitals or health departments. So despite that, the model in terms of how these were being commercialized was changing pretty rapidly. So what are the consequences, especially from a clinician perspective, of exempting LDTs from FDA oversight? We saw, the surveys of asking laboratory managers around kind of what has been the benefit of these sort of exemption has really been around patient access. The idea that you could rapidly translate these tests to clinical practice to be able to pick up on diseases potentially earlier. However, it did introduce risks associated with this, and the idea of potential patient harm due to the lack of FDA oversight around clinical validity. Again, this idea of whether or not these tests are measuring something meaningful for patients and also things that are associated with clinical outcomes. As an example of this, folks might be aware of this, there's been millions of LDTs that have been performed in these CLIA certified laboratories for non-invasive screening of prenatal disorders. So Down syndrome as an example, or trisomy 21. And independent analyses have found, and multiple actually analyses have found that these tests, many of which are still available today, actually have substantial false positive rates. And this actually triggers a pretty invasive care cascade for patients, especially in vulnerable populations. So typically, if these tests show a positive trisomy 21 diagnosis or result, this would lead to a clinician to be able to talk to a patient about further invasive testing, including amniocentesis, which you can see on the right here. It's a very large needle that actually goes through the abdomen into the uterus under ultrasound to be able to collect amniotic fluid to confirm the diagnosis of trisomy 21. It also comes with a non-significant or a significant risk of miscarriage. That's something we always tell our patients when talking about the use of amniocentesis versus other sorts of methods as well. And so you can imagine for a patient who might be very concerned about this and who wants a confirmation, this could be something, potentially even traumatic, especially if the test ultimately comes back negative, and having a test, the LDT at least, that has a high false positive rate. For clinicians, though, a lot of information about testing accuracy is unknown to them as well as the patients, as manufacturers are not required to generate the data demonstrating clinical validity prior to commercialization because of this exemption. And this is particularly concerning because we were seeing LDTs being marketed without evidence for conditions for which the FDA-approved diagnostic already exists. So it essentially created kind of this parallel market for LDTs that were easier to reach to patients without any sort of regulatory oversight as well. And we also saw companies kind of intentionally doing so because it reduced their costs of regulation from the FDA. So there's been concerns also raised around this idea of analytical validity, the idea of accuracy of these tests as well. CLIA, this paradigm that was passed through Congress that gave CMS authorities around this. Actually, there has been several analyses since that found that there's been deficiencies in relation to analytical validity. And one study found up to 16% of laboratories are considered deficient in terms of meeting standards under the CLIA requirements. This leads to significant clinical consequences for patients of having unreliable tests, having tests that either show a false positive and leading to inappropriate treatment, or as I mentioned before, cascades of care that might be very invasive, in addition to also false negative tests, which also can lead to delays in care for patients as well. There's also significant consequences for the health system overall, especially in its ability to respond to public health emergencies. And we actually saw this during COVID. During that time, HHS actually directed FDA to exempt LDTs for the diagnosis of COVID-19 from pre-market review. And later on, various sort of independent studies actually found that about 66% of tests, 66% of these tests that had been authorized by the FDA, including under emergency use authorization, were actually had problems with in terms of test design, validation, or also performance standards. And several of them were also subjected to FDA safety communications and recalls. This information is actually publicly available. You can see it online in terms of the safety communications and recalls. And a lot of this wasn't actually translated to the public. So you would see stocks of these tests being made available in various pharmacies, clinics, even schools, in which FDA or actually independent analyses found out later on that these tests actually were not working as they were supposed to. So all of this has prompted both legislative reform, but also FDA reform proposals for LDT regulation. So first I'll go through the FDA or the legislative reform side. In the mid-2000s, following several of these investigations, reports from the FDA, inquiries from Congress as well, the Verifying Accurate Leading Edge IVCT, or an in vitro clinical treatment development to act, was actually introduced, what we call the VALID Act more colloquially. The idea is that this would actually explicitly grant a new regulatory regime for all in vitro diagnostics, including LDTs, outside of medical devices. So it moved the authority for our in vitro diagnostic tests outside of the medical device amendments into a separate authority under the Food, Drug, and Cosmetic Act. The idea is that it's similar to medical devices. You'd still have a risk-based approach for FDA requiring pre-market evidence to be submitted to them ahead of approval. And it also codified the ability for FDA to still ask for non-clinical information. So things like performance standards, and also on the post-market side, very importantly, being able to do surveillance studies and also issue surveillance requirements for these products. This has been considered multiple times in Congress and actually had support from the medical device industry. This is a quote from someone at Roche. The medical device trade organizations, AdvaMed, also expressed support for this, albeit with some changes that they were requesting. But you can see that there was a lot of groundswell around this, except, as you can imagine, individual laboratories, academic medical centers that also had laboratories, and also the increasing number of kind of AI-enabled LDTs that were also coming out as well. There was a lot of pushback from them in terms of blocking access or blocking this bill from moving forward. In response to that, FDA was seeing this and also seeing kind of the growing tide of LDTs coming before them and also putting out reports of harms from these tests out to the public and decided to take action. They proposed a new rule in 2023 that clarified their authorities over lab developed tests, also asking for updated performance standards. They also created a user fee way to fund their regulatory activities with this. So the idea that when applicants that had a potential LDT that they wanted to get FDA approval for, before they come to market, they would actually pay FDA a user fee in exchange for FDA being able to hire staff to review their application and to be able to grant marketing authorization. There was also exemptions given for low risk tests. Again, this idea of risk-based approach as well. And further requirements around the post-market surveillance side, especially for high-risk tests. The idea was that they wanted to align LDT regulation with existing approaches that they had with in vitro diagnostics overall. So just some examples. High-risk tests would be these new tests that have come out around diagnosing Alzheimer's disease based on various biomarkers. That would require manufacturers to submit an application with evidence of its clinical validity as well as its analytical validity ahead of approval. And then low-risk LDTs, like measuring blood sugar, they would be subject to enforcement discretion. And FDA could just say, okay, you don't need to actually submit an application to us before you hit the market. FDA issued this rule. They had a Federal Register notice asking for comments. Many stakeholders put in comments related to this. And so this is from our paper where we actually looked at the over 6,000 comments that were submitted to FDA around the proposed regulation of LDTs. And you can see it kind of runs into kind of two broad categories. Obviously, support for expanded oversight of LDTs, are really arguing around this issue around patient harm, especially as the market has grown for LDTs, and also the consequences of this sort of regulatory inconsistency that was occurring right now. Then there was also support for maintaining the status quo, so the idea of continuing to exempt LDTs from providing any information before they were being made available to patients, saying that you already had existing regulations, especially under CMS with CLIA, that FDA doesn't actually, under the law, actually have this authority explicitly to regulate LDTs. They said this would disrupt clinical care because this would stop the availability of tests for clinicians and patients to be able to diagnose diseases earlier on. This actually came from the American Medical Association, which, as a caveat, there are several financial ties as well with the folks from the stakeholder side expressing support for the status quo with the laboratory associations as well. There was also arguments around impacts of future diagnostic innovation, basically saying if you put in regulations in place, creates an additional barrier that manufacturers have to face and also additional costs that will stymie innovation. And this came from the American Public Health Laboratories Association, which represents several groups that produce LDTs and also move towards commercialization as well. So as an example of folks who actually issued concern or expressed concern around maintaining the status quo, who are calling for the expanded FDA oversight of LDTs, I'm just going to show you this example of Medimap. This is one that FDA has talked about, and then where they've tried to actually use their enforcement discretion to some degree, but had difficulties doing so because there wasn't a clear regulatory regime for them to be able to pursue this under their current regulation and guidances. And this was oftentimes cited as kind of a reason for why FDA should definitely have some sort of regulatory authority around LDTs that was already codified under medical devices. So Medimap is a platform of these pharmacogenetic tests for predicting medication response to different conditions, including diabetes, depression, that was marketed by a company called Innova Genomics Laboratory. This came onto the market in around 2016. That's when we saw the initial versions of Medimap coming forward directly to patients. And FDA actually issued a warning letter about 3 years later in 2019, citing the lack of clinical validation for these tests, and also requesting the manufacturer perform additional testing and implement changes to the product's label. The company was kind of stating a lot of claims that were actually, clinical outcomes, very important to patients, that FDA was not finding any sort of least transparent form of evidence around. The manufacturer actually declined to do so in response to FDA's letter, arguing that Medimap was actually an LDT and wasn't required to actually comply with FDA's regulatory requirements. And this episode kind of illustrated very clearly kind of how these historical flexibilities around enforcement discretion, this split between FDA versus CMS authorization, has produced contemporary challenges for enforcement. So it's pretty incredible, just to see this as an example, but it was a really good example of why FDA should have authority around this. So FDA then finally issued the final rule in May of 2024, saying very clearly that they do have regulatory authority over LDTs. They're going to start requiring evidence being submitted to the agency before authorizations of high-risk LDTs, and that they were going to start collecting user fees. Once that happened, a lawsuit occurred almost immediately. It seemed like it was already primed from some of the public comments that we saw as well. But this was a lawsuit that was filed in the Eastern District of Texas from the American Clinical Laboratory Association against the FDA. They also had a company, you can see here, Health Track RX, which is actually an academic pathologist who had a kind of a spin-off company from the university that he created, who was also a plaintiff on this case. They were also joined then later on with the American or the Association of Molecular Pathologists, or AMP, and also another academic clinician that had a startup company producing LDTs. Essentially what they asserted is that laboratory developed tests are not physical products, but services being offered to patients. And that's why CLIA and CMS have the authority to actually regulate this, and FDA doesn't. And that the various attempts to actually pass the VALID Act in Congress was evidence that FDA did not have clear statutory authority, especially with the fall of Chevron, to be able to claim regulatory authority over this area. So this is the complaint that was put forward. We wrote an amicus brief about this, very concerned, not just about what this would mean for LDTs, but also for other products as well, in which FDA has used and harnessed the medical device amendments and its broad language to be able to interpret its regulatory authority. So this is something that we filed shortly after the plaintiffs, or the other supporters of the plaintiffs, also filed their amicus briefs. Unfortunately, I'll just kind of cut the story short so we can go to questions. Unfortunately, the judge ruled in favor of the plaintiffs, and FDA was required to vacate their rule or appeal. So this happened in late 2025, or sorry, March 31st, 2025. So just to kind of go through what the court said, the court agreed with the plaintiffs' claim that LDTs are services, not devices. Essentially, they argue that LDTs don't fall into the definition of medical products that are regulated by the FDA, but professional services. We wrote a counter argument in our amicus brief in terms of why this is not the case, using the case of like surgical tools that are used in surgery. LDTs in our mind are similar to this. These are tools that are used by clinicians to be able to offer services, but they are tools in and of themselves, and thus medical products. They also said that oversight of LDTs is the responsibility of CMS under CLIA. Again, kind of ignoring this idea of clinical validity oversight and maintaining just analytic validity. And then also finally raising this issue around the major questions doctrine, citing the Supreme Court case that overturned the Chevron doctrine, saying that Congress had not explicitly given FDA authority around LDTs, and that the regulation constitutes significant economic and political importance, so that it requires explicit congressional authorization to do so under the major questions doctrine. And our big concern related to this was how FDA was going to be able to move forward in adapting regulatory frameworks to emerging technologies. including AI-enabled medical devices, which have grown, and also new other, and how FDA might respond to other new public health challenges. So this is something that we here have been deeply concerned about and are watching as a fallout of this case. We actually wrote to the FDA and wrote some op-eds asking them to appeal this case, saying that this would really stymie their regulatory authority in many ways, but FDA declined to do so. Earlier last year, or late last year in September, they rescinded the rule. So again, as I mentioned before, really stemming from kind of the fallout of the Chevron doctrine being overturned. I'm just putting this up here because we had written also an amicus brief around the Loper Bright versus Raimondo case as well, specifically around the impacts on FDA authority, given that FDA has done a lot of statutory interpretation in terms of promulgability regulation, in terms of its authority around medical products. So just I'll kind of like step to where we are now. The market for LDTs since the rescission of this rule has exploded. And I say this both from a clinical standpoint, actually having patients come to me in my office in New Haven. I work at a federally qualified health center. I actually see a lot of folks who are usually uninsured or underinsured. So these are things that they are buying with their hard-earned dollars and limited dollars instead of things that kind of come through the typical prescription process that have not been vetted. They've lots of social media around these LDTs, these diagnostics, lots more LDTs being available to patients, especially for things like Alzheimer's. So I've seen so many advertisements and also patients coming to me with tests that they've received for being able to diagnose Alzheimer's disease early on, multi-cancer early detection tests. So the idea that you're able to diagnose any type of cancer with one single test, that's something we're also seeing directly marketed to patients, and also AI integrated diagnostics. This idea of being able to predict using AI whether or not you're going to have an immunological response to various drugs, to various foods, etc. So a lot of commercialization opportunities that have been achieved really through the rescission of this rule, and also FDA not appealing this court decision as well. Again, we still have CLIA, the idea of like laboratory testing and CMS having laboratory standards being overseen, but still issues in terms of whether or not that enforcement is actually occurring, and variation in terms of performance standards as well. In response to this, because we and other folks have been keeping up with the harms and trying to articulate this to members of Congress about why we still need congressional action around this, there have been legislative efforts to revive the VALID Act. There was a clean version introduced this past Congress, but it's much more streamlined and provides kind of further exemptions. They're hoping to kind of assuage the folks that had killed the bill earlier on. The idea is that you have a broader grandfather clause that would exempt local LDTs. So you might have an LDT that's marketed to a kind of a regional area or a local area. Those would be exempt. It would also allow for a lab to get a single certification for a process instead of for a single test. So this could, you can imagine you might have a big lab that produces various different types of tests. As long as they're certified, they don't have to provide individual pre-market evidence around each and every test to the FDA, which is also somewhat problematic as well, as we've seen. It still continues to codify this idea of the CMS FDA hybrid approach around regulatory oversight for high-risk devices, LDTs overall, but again, having enhanced regulatory oversight for high-risk devices, high-risk LDTs for FDA. It provides also funding and review capacity to the agency through user fees. So the idea that the laboratory industry will pay fees on an annual basis along with each application to be able to fund staff to actually look through the applications and also negotiate how these fees will be used by the agency. There's been counter efforts to this in Congress, including the Freedom for Laboratory Innovation and Testing Act. It's an anti-valid bill. The idea is that it wants to codify the court's ruling to permanently bar FDA from regulating LDTs, and also CLIA modernization. The idea that we might try to improve CMS's oversight, at least around the analytical validity piece to some extent. This has been coupled with issues around coverage. So there's been bills in Congress to basically require CMS to consider coverage for these tests. So this is a bill that just passed in the House of Representatives this past year for the multi-cancer early detection tests, where essentially CMS has to issue a national coverage determination around whether or not they will cover these tests. So it's coupled with this idea that FDA doesn't have evidence around its clinical validity, but CMS still has to make coverage decisions around these products. So it's very concerning in many ways. We can imagine from an access perspective, there's going to be a lot of clamoring for these tests, but from a quality perspective, we won't necessarily have information to know whether or not these tests are meaningful for patients in any sort of way. There's also financial consequences related to this. This was a great two-parter where one on the left, there was a group that actually did a systematic review of any evidence around available multi-cancer detection tests, finding basically no published evidence or no controlled studies that have been published related to these tests around clinical validity. And on the right-hand side is this editorial piece from Dan Weinberg, who's at UPenn and who's an oncologist, who talks about the larger consequences for patients, including the financial consequences. And there's actually a recent projection that estimated that the multi-cancer detection market alone in the United States could exceed 4.3 billion by 2033. So kind of massive commercialization opportunities, but also massive financial consequences for our patients and also the health system as well. All of this, though, we talk about like enhancing FDA's authority. We also have to talk about it in terms of like the practical terms and the political economy that we're in right now, in terms of the FDA being dismantled. So this is kind of a larger piece that has unfortunately become more and more prescient as time has gone on in terms of the changes at the agency, in terms of, especially around attrition of the workforce, that has really hampered its regulatory capacity. So this was just from August this past year. I just checked and see if there's any sort of updates, especially on the device side. This hasn't changed much. We still see about almost a quarter of FDA's regulatory capacity either who've been fired under the reduction in force measures with DOJ or who've left the agency still occurring. FDA is not being able to rehire or restaff at the capacity that it's lost people. And especially on the device side, we see more and more people leave than we see more people enter. So this means that FDA's ability to even enforce any sort of regulatory regime has been severely hampered as well. And this is coupled with this idea that at the agency, we see leadership talk about these principles around radical transparency, gold standard science, removing conflicts of interest, and restoring public trust, all of which require regulatory capacity and also really political will from the agency to be able to step in, to be able to do its job in terms of making approval decisions and sometimes also preventing products that are unsafe from the market. The actions, unfortunately, from the agency have kind of run counter to this. In many ways, these principles have been invoked, but the actions kind of have been the opposite in many ways, in which speed and efficiency and access to patients is being prioritized instead of its regulatory role overall. And I know Patty talked to you all earlier this year or last semester about this in terms of what this means for the agency and its ability to move forward as an agency that's intended to protect public health and ensure public trust in its regulatory decisions. So I'll stop there on that little bit of a somber note, unfortunately, and I'd like to take any questions.
So many questions. Thank you so much for that amazing talk. I have a few myself, but if anyone wants to ask a question, I know we covered a lot, then just put your question in the chat. But to get it off, I wonder if in thinking about this sort of the challenges, how you think about the growing consumer distrust of healthcare providers, and does that somehow make this problem so much worse? And is that something that's being fueled by these LTDs as a sort of a market through marketing?
Yeah, definitely in many ways. I mean, you're right. I mean, I think in public health institutions, healthcare providers overall, there's been growing mistrust. Obviously, the COVID-19 pandemic played a huge role in terms of in the midst of uncertainty, there was decisions that were being made and oftentimes political decisions. And then later on, we found evidence to either support or refute those decisions. And, post hoc or in hindsight, it's very easy to kind of say, things were wrong, you made the wrong decisions, but that shouldn't necessarily be a marker that the agency overall, is wrong. But it's been taken that way in many ways. I think the other part of this too is how patients and also even as clinicians, how we gather information about products has changed in many ways. Now we have, information that's coming to us, especially through like social media, a lot of channels that are kind of directly going to patients that are offering them, signs of hope. And you can imagine, as someone who has cancer or who's worried about cancer or Alzheimer's, if there's a test available that can detect this early, in which you're, articulating this narrative of FDA being the barrier to access because of its onerous and, expensive regulatory requirements, that's a very compelling narrative. And especially coupled with like an anecdotal evidence of like one or two patients who might have said, I was able to get diagnosed with pancreatic cancer. And this is exactly what happened on Capitol Hill that led to that multi-cancer early detection test bill actually being passed. They actually had patients who were from the company being hired to go to various senators to kind of articulate their story around this. But this is also something we're seeing in social media as well. So I think how that sort of interface has changed a lot in terms of how patients also interact with health information, but also how clinicians do as well. And especially clinicians who work in areas where we don't have a lot of options or our diagnostic capability is not yet up to snuff where we'd hope it would be.
Great. We have a question from Eric Connick. Aren't direct-to-consumer tests regulated by FDA unless there's a physician in the loop placing a test request? Many DTC companies have physicians or providers who ostensibly evaluate the testing request and fulfill the order if they believe the test is reasonable.
So direct-to-consumer tests are not regulated by the FDA. Again, it's a risk-based approach, and specifically LDTs as the product itself. FDA has, again, tried to put forward regulation to assert its regulatory authority over these tests, but now it's been vacated. So basically, those tests are not being regulated. So then it becomes a clinician's decision about whether or not they recommend the test. We see, and we've done some secret shopper studies, we've done, various sorts of follow the money sort of studies, significant conflicts of interest between those who are hired by those direct-to-consumer platforms and the clinicians who are recommending the tests. Sometimes even having these are companies that they have started. So obviously they want to have a market. So they're going to promote these tests despite the lack of clinical validity behind them. And we also see how the test results are being interpreted by the clinician also being incorrect. And some of it might be misunderstanding in terms of how the tests operate. They don't have access to evidence around how well the test does because that was never required in the first place. And secondly, there might be, kind of this idea of like, well, if the test is potentially positive, we want to take kind of the no harm done sort of approach and try to recommend the kitchen sink so we can confirm that something's not a problem. Like, if there's a risk of anything possible, we as clinicians typically try to order everything to kind of make sure that we're correct in the first place. So I think it's a mix of both, unfortunately, but it's been very difficult to track, again, because these are not necessarily medical devices, as FDA has now stated by vacating the rule, so we don't have a way to track them as well.
All right, we have a question from Risa Jampal. How many of the LDDs are recommended by physicians, clinicians to patients, and are done in physician offices versus marketing direct to patients? So LDTs cannot be purchased directly by a patient. Is that true?
No, LDTs can be directly purchased by a patient. So if you actually go to your, if you even through Quest Diagnostics or LabCorp or some other places, you can actually order an LDT yourself as long as you have the ability to pay for it. Whether or not it's going to be covered by insurance is a whole other thing, right? Because that typically will require some sort of physician sort of authorization. But now we also see letters that are coming from clinicians who are hired by the direct-to-consumer platforms to be able to ensure prior auth or basically insurance authorization for those products. That's a good question of how many. There's no database of how many LDTs because they're not required to be registered with the FDA. So for us even to capture what the denominator is, it's impossible. And we try to do sampling studies where we're scouring the internet to be able to find all these, but literally on a day-to-day basis, we see a new test being come up and also being mass marketed to patients. So it's been a moving target. I'll just say from our experience though, we've seen a shift from physician office recommendations or hospital recommended tests to these online direct-to-consumer platforms. The uptick has been pretty significant in that space.
Interesting. Is the view of LDT similar to that of compounding pharmacies? It seems like they have similar origin as the mom and pop or neighborhood store practice. That's a question from Kenneth Wong.
Yeah, it's a great question. They do have like a similar origin story in many ways. Compounding pharmacies in particular were meant to serve a need, one in the case of shortage, or if there was an issue of that drug specifically for that patient, like a product that was inactive that the patient might have a reaction to, or if you need to add something else so that could be more palatable to a patient. That's how compounding pharmacies have emerged. And now they've become these sort of mass marketing entities that they were not intended to be. So in some ways, I think it is very similar. And we've done like similar secret shopper studies with the compounding pharmacies and their telehealth platforms, where the findings are very much reflective of what we see on the LDT side. Essentially, like no clinician involvement. You put your credit card in, you get automatically charged in less than 5 minutes. You'll get a new drug at your house that might be mixed with something else that has not been tested necessarily as well. So it is pretty similar in that sort of way. And part of it is because there is like a lack of like regulatory authority for FDA in terms of having oversight or even like registration of these pharmacies with the agency, unless they're a certain type of pharmacy.
So we have a few more minutes for questions. And I was just sort of wondering, in terms of, um, one could say it's a little bit of a bleak landscape. And so if you're thinking about, and you may not have an answer to this, but in terms of areas for intervention, right? So particularly looking at the growth in the consumer kind of purchase, the direct-to-consumer marketing and the consumer purchases, where are kind of public health folks and people and, in medicine looking for interventions?
Yeah, I mean, primarily right now, there's been two different ways that we've been and others have been looking at interventions. Again, one is through continued congressional action because of hearing of instances of like either patient harm or patient cascades of care, right? Like they're going through this whole stressful care process because of tests that ended up being inaccurate. Making sure that's being also voiced to members of Congress. It does seem that there will be some form of a ballot act being passed, not because of the harm issue, but because of the cost issue. As you can imagine, like I think the term of today is like affordability, and also thinking about like our healthcare system and how much it can actually bear, especially in terms of cost. And I think CMS and also health insurers are just seeing this landscape of CMS and insurers having to pay more and more for these tests, where we don't even know whether or not they're like reasonable, necessary, safe, effective for the patients who are covered under these plans. So from that perspective, like folks in Congress kind of care in some ways, but they run into a lot of, I think, roadblocks because you can imagine there's different groups are asking for exemptions. Academic medical centers want a big exemption for them. These local local laboratories want exemptions for them. And it winds up like chipping away at the regulatory regime that FDA might have, but at least it's a start still moving forward. So I'll say that there is some action on that. Secondly, the other area in which like we've tried to do some work on is actually around this issue around states, whether or not they might be able to take action in terms of making examples through litigation of harm from these tests. Identifying kind of harm has been the difficult part around this, as you can imagine. But we have a couple of examples here and there that we've been working on with some state agency offices to be able to put forward as potential, at least lawsuits that could set a precedent for, clarifying FDA's sort of regulatory authority in this space. So that's going to be the other one. And then the last bit I'll just say is like, medical professional societies guidelines. That's going to be a key part of it too, especially because some guidelines, especially in the cancer space, are tied to reimbursement and coverage. So if it's not in, like, for instance, in the National Comprehensive Cancer Network guidelines, then Medicare isn't required to cover it. So like there's different paths through that to actually ensure that clinicians are also reviewing the evidence themselves from a guideline perspective level, so that they can have some oversight in the back end. But again, these are being directly marketed to consumers. So for me, when I see patients who bring tests to me, it's only the tip of the iceberg. There's going to be so many more patients who are not mentioning these tests that they're potentially buying themselves online that I just will never hear about.
Great. All right. Well, we have time for the last question, and fittingly, Karen Rothenberg gets the last question. Have there been any lawsuits in which incorrect or incomplete test results have resulted in serious harm?
Yeah, we were just like actually reviewing some of the evidence around this. There have been some lawsuits related to Medimap in particular that we looked at. Those didn't go very far, unfortunately. There was also a lawsuit related to these kind of at-home sexual assault kits. We also wrote some things about this too, but the idea of these sort of tests being directly marketed to consumers and going to a single laboratory as well. States have actually taken action on this in particular, but it's state by state, so it's like a patchwork of different like laws in terms of regulating the use of these. There hasn't been really a good, I would say, test case for some of these like newer regime of LDTs that we're seeing coming out there around early diagnosis of disease, multi-cancer early detection tests, in part because the harm issue has been really hard to identify in some ways.
Well, that gives us a lot to think about and lots of research opportunities for anyone looking for summer projects to try and figure this out. But I want to really warmly thank you, Dr. Ramachandran, for sharing your expertise on this incredibly important and impactful subject. And just really, you covered so much more than just the sort of the specifics of LDT, so a lot to think about. I also want to thank the Law and Healthcare Program Faculty Director, Diane Hoffman, the Managing Director, Rebecca Hall, as well as warmest thanks to Karen Rothenberg, who generously makes these talks happen. And special thanks to Gihan Gurji, our health law program specialist, who so expertly coordinates all the communications and technology that make these events work. And I want to wish everyone a wonderful summer and hope that you'll join us again in the fall. So warmest thanks to everybody, especially to our speaker who's left me and all of us just a lot to kind of digest. So thank you so much.
And thank you so much. It was nice to see you all.